Hi guys, Dr. May here. I'm just preparing a short video for you guys to revisit some of the concepts about biofilms that we talked about in week 6, and also to talk about how biofilms are involved in subacute endocarditis and some other clinical diseases. We saw this slide in week 6, which was the bacterial pathogenesis set of slides. And I want to just revisit it quickly to refresh your memories, because it's rather important to appreciate how these things develop and what exactly a biofilm is in order to really get a handle on the clinical relevance. Bearing in mind, this diagram is from the Journal of Dental Research, so they're specifically talking about teeth and tooth surfaces. I'll get back to in 1 second the other types of surfaces that are relevant for our clinical presentation. So we're going to talk about, for all intents and purposes, think of this bar down here as any kind of solid surface, okay? The very first thing that's going to happen, just again to refresh your memory, is that some bacterial cells that are floating around, in this case they would, at this point they would be called planktonic cells, they're going to find their way to a surface and they're going to attach and adhere. At this point we're going to call them sessile cells. When these guys start aggregating on a surface, they start secreting and producing some very complex carbohydrates and long-chain glycans. And as they start doing this, these glycans start interconnecting and they start forming what will eventually become a biofilm. All this gray jazz in here would be these interconnected networks of glycans which were produced by these bacteria. As this gets bigger and bigger, it starts attracting additional bacteria if they happen to be in the system. You could imagine in the oral cavity, you're going to have a lot of different types of microorganisms present. And so anytime you have something nice and gooey and sticky forming, you're going to have multiple types of species. When we get back to talking about endocarditis in a little bit, more than likely you're going to have a pure species biofilm because there aren't a lot of other different types of cells floating around that are going to be able to co-colonize. But I digress. As this gets larger and more complex, you have additional organisms that are going to join the party, start producing additional carbohydrates and ligands, and this structure is going to only get bigger and more complex. Down here on this diagram, you see a lot of references to things that are very cool bacteriological principles, and they are, in my view, quite related to infectious disease. But clinically speaking, we want to focus on this point right up here. This biofilm creates an extraordinarily nice, tight, protective shield around the organisms inside of it. And this protective shield is going to keep out antibiotics, it's going to keep out reactive oxygen species, it's going to keep out antibodies, basically everything natural and human-derived that we would employ in order to kill these organisms. The biofilm is going to protect them from it. So you could see how if you have a patient who has an infection that is going to have some biofilm involvement, you're going to have to take that into account in your treatment plan. Okay, biofilm formation can actually be a very useful diagnostic marker. What you have here is an image of an agar plate, and for any of you who've either done a microlab or taken a microlab, this technique is actually called an isolation streak, where you streak a whole bunch of bacteria on one side of the plate, and then you start dragging it out and diluting it out to try to get individual colonies. But what you see here, rather than nice, neat individual colonies, you actually see these big clumps of yuck, for lack of a better term, if I may. if I can kind of just point this out, if you look right here, this is where you would ordinarily be seeing a bacterial colony. Here, let me put this in red to make it easier to see. And all of this external stuff here are these secreted glycans and secreted materials. This is extraordinarily characteristic. Bacterial growth on agar plates does not normally look like this. It doesn't have this crinkly appearance, and it certainly doesn't have this halo of goo around it. Your clinical microbiologist that you interface with someday, if you have a good working relationship with them, which I humbly suggest you try to foster and develop, they will be able to tell you the patient that gave this sample, this is a very strong biofilm former, and so you're going to have to alter your treatment protocol accordingly. So I'll tell you in a few minutes how you have to alter it to take biofilm formation into account. But anytime your clinical microbiologist either shows you a plate with this kind of appearance to it or tells you they have a plate with this kind of appearance to it, you definitely want to think to yourself, this is making a profound and substantial biofilm, and I am going to have to extend my treatment protocol accordingly. If you can imagine going back to this guy for a second, all of this goo being added to the surface, to the alveolar surface in a lung. All right, so once again, the clinical relevance of biofilms, these can form on natural body surfaces. So you already saw a diagram of this happening on a tooth, but you also want to think about bone. You also want to think about tissue. And in particular, there are a couple to bring up. One would be heart valves, which you could imagine I'm going to talk about in a minute. Another would be alveoli in the lungs. Okay, so natural body surfaces in addition to teeth. There are quite a few. And these are by no means the only ones, but these are just some notorious ones. Medical surfaces. This is any surface in the hospital that can be, gurney railings, that can be door handles, that can be tubing in a respirator, anything like that, has the potential, if it gets seeded with these organisms, to have a biofilm develop on it. And when that happens, just as biofilms protect microorganisms from antibiotics and antibodies, they also tend to protect them from disinfectants that are used on hospital surfaces. The last point to bring up for biofilms and their clinical relevance would be medical devices. So we talked about this briefly in week 4, I believe, when we were doing our whirlwind tour of clinical bacteriology. We brought up specifically urinary tract infections and how when you have a catheter-associated urinary tract infection, very frequently you have these very prolific biofilm formers, and you have to give the patient a much more stringent course of antibiotics in order to actually treat the infection. So catheters are very notorious as acting as solid surfaces for biofilms to start forming on, but they're certainly not the only ones. You can have prosthetic valves, you can have ports, you can have pacemakers, anything that is a nice solid surface that gets into a body that's prosthetic has potential for biofilm formation on it. I've also put down here gram stain images of 3 very clinically important biofilm formers. This one right here, Enterococcus, is absolutely notorious for catheter-associated UTIs and also subacute endocarditis. So let me put that here, UTI and endocarditis. This guy over here, Staph epidermidis, also very firmly associated with catheter-associated UTIs. This guy in the middle is Pseudomonas aeruginosa. This is a very, very difficult organism to treat and deal with, if it gets into the alveoli of the lung. If you could imagine going back to this. Sorry, I'm getting a funny message on my screen. I hope this didn't come out strangely. So all of these glycans and carbohydrates just basically starting to, if this is an alveolus, starting to coat the surface of the alveoli, you could imagine you're really going to have a difficult time mediating gas exchange and breathing. In addition to that, these are bacterial agonists that are sitting on the surface of the alveoli, so you're also going to have acute inflammation happening. You're going to have degranulating neutrophils. You're going to have all kinds of just terrible things happening in here, so you wind up with an inflammatory exudate and a very substantial and severe pneumonia. Because you have the organisms inside of a biofilm, again, they are quite difficult to treat. This organism, many of you may have heard of being associated with cystic fibrosis patients who have a difficult time producing mucus that's appropriately thin. They produce extraordinarily thick mucus that's difficult to cough out. And so when you compound this situation on top of already thickened mucus, which, by the way, is a great source of glycans, for additional incorporation into a biofilm, you really have an infection that's incredibly hard to treat. Okay, so that's all I want to say about biofilms, clinically speaking. What I want to talk about now is what they have to do with something called subacute endocarditis. This week's case was a case of acute endocarditis caused by Staph aureus. So you saw, hopefully, how that organism comes in, produces a whole lot of pore-forming toxins, causes acute cell death, and mediates cardiac damage by its toxins and by the inflammatory response that it incites. Subacute endocarditis is quite different, both in clinical presentation, the types of organisms that cause it, and how you go about treating it. So first and foremost, to talk about what subacute endocarditis actually is. This is a chronic infection of the heart valve. If we look at a heart from taking kind of an axial view here, and we do, this would be left atrium, left ventricle, right atrium, right ventricle. Let's pretend for a moment we have an infection of the mitral valve. Okay, let's say here that this is a nice solid surface, and we have the deposition, obviously drawn not remotely close to scale, of some bacterial cells. These guys, if they are good biofilm formers, what they'll do is they'll start secreting their glycans, and then ultimately what you'll end up with is a mitral valve with a big giant film on it. So we just mentioned a second ago with Pseudomonas, these are bacterial components. They are going to elicit an inflammatory response. So ultimately what you're going to have here is an inflammatory infiltrate at this point, and this is going to become even more sticky and gooey, and this would be what we would call a vegetation. I know you saw this also in your acute endocarditis case, but the vegetation that forms in subacute endocarditis is of a much more chronic nature. It develops far more slowly. You could also imagine, when you think about what the function of the mitral valve is, if you have all of this crud, for lack of a better term, stuck on it, it's not going to function very well and very efficiently as a valve. So one of the first clinical signs that you see in a subacute endocarditis patient would be the development of a heart murmur in a patient who did not previously have one. The type of murmur and where you hear it is going to also obviously clue you in onto which valve is being affected. So murmur is the first one. The other clinical presentation that you see here with subacute endocarditis is fatigue, fever, but it's of a lower grade. It's not quite so dramatic as with an acute endocarditis. And just kind of a malaise, kind of a feeling awful. A patient will come in with this, and oftentimes it'll be, 3 or 4 weeks in duration. They basically will come in, complain of flu-like symptoms, and if you listen to their heart and hear a murmur, again, in a patient who did not previously have one, then this might be something to think about. The way you diagnose subacute endocarditis, other than with ultimately with imaging, is that you would request blood cultures and cardiac enzymes as well. If you see an elevation in cardiac enzymes and a positive blood culture, then you'd want to speciate what organism you have, but at that point you're on safe grounds to diagnose subacute endocarditis. So the organisms that are most likely to cause this typically belong to this family. I spelled that terribly wrong. Give me 1 second. Sorry. All right, there we go. Enterococcus species. So we previously met Enterococcus when, again, we were discussing catheter-associated urinary tract infections, as we mentioned on the previous slide. Enterococci are very prolific biofilm formers, as you could imagine by their repeated mention in this little video. One tricky thing about this is that Enterococcus is a reasonably new name for this group of organisms. I say reasonably new, it's about 15 years old at this point, but previously these were referred to as Viridans group Streptococci. So you often will still, to this day, see that nomenclature in treatment recommendations, or you might hear it by physicians. So just to repeat and clarify, Viridans group Streptococci, or Streptococcus viridans, which is totally not a legitimate organism name, those are now called Enterococcus. You may consider them interchangeable. You heard it here first, or for the several thousandth time in the past 15 years. But anyway, just to avoid confusion when you're preparing for the board exam, anytime you see this term, think this, okay? All right, if we've not flogged that enough, now we want to talk about how do you treat subacute endocarditis, and what's a greater general rule when you're talking about treating an infection with a prolific biofilm former. One of the rules of thumb here is that you're going to have a longer course of antibiotics. The reason for that is that if you give a standard course for any Enterococcus or Streptococcus infection where you do not have a biofilm present, it's going to be somewhere in the order of 5 to 10 days, depending on the antibiotic. When you have a biofilm, the shelf life of that glycan structure is longer than 5 to 10 days. So what would end up happening is that you would kill any planktonic cells. Once the antibiotic was no longer there, the biofilm that is still intact, because you still have living cells on the inside of it, that's just going to reseed the entire infection. So what you have to do is treat with antibiotics for longer than the shelf life of the biofilm. Typically, that's going to be around 8 weeks. So that is a very big difference from 10 days, obviously. That's why it's so important to have good communication with your clinical microbiologist, who can tell you, hey, I got this species, and by the way, it makes a really nasty biofilm. You might want to treat for longer. That's a really important principle that I hope to impart on you. That is a general rule with biofilm infections. When we're talking about how to treat subacute endocarditis specifically, just so you can look at this later and know what it means. Typically, you're going to use as a first line penicillin G to treat this. You're going to administer it by IV because you're dealing with with an endocarditis. Obviously, that's the most direct way to the most direct and effective way to access and treat that infection. If you have a drug-resistant or moderately drug-resistant, you would give a higher dose Pen-G plus an antibiotic called gentamicin. This is an aminoglycoside. It's one of those groups that we mentioned briefly, targets ribosomes. So this is going to target cell wall. This is going to target ribosomes. If that still doesn't work, at that point, you go here to vancomycin. There is no need in a subacute endocarditis patient to use this in an initial therapy. With an acute endocarditis patient, it's a different story because you're talking about hours till death rather than months. With a subacute endocarditis, you absolutely want to wait for susceptibility testing because you may not need to use this drug. And that patient is not going to drop dead before you get those results. That is something that is really imperative when you're making treatment decisions or answering board exam questions, that you do not think about infective endocarditis as one thing. You really have to consider the differences between acute and subacute. Okay, I hope you guys found this video helpful, and good luck on your progress tests, and have a great holiday. Talk to you soon. Bye.